thank you for joining the University of Washington Division of Rheumatology Grand Rounds. A couple of reminders before we start. This session is currently being recorded and it'll be posted later on our website. There will be a Q&A session at the end, so please add your questions in the Q&A feature and not in the chat box so that it's easier to moderate. And now I'll let Dr. Najjar introduce our speaker for today.
Good morning, everybody. It is my pleasure today to introduce Dr. Andrew Mammen. Dr. Mammen completed his medical training and PhD at Johns Hopkins. After that, he completed a neurology residency and neuromuscular fellowship. Dr. Mammen co-founded a Myositis Center at Johns Hopkins in 2007 and co-discovered a type of necrotizing myopathy with HMG-CR antibodies. Then Dr. Mammen joined the NIH at NIAMS to lead the muscle disease unit. And one last thing I'll say, which we alluded to earlier, is that Dr. Mammen is a Seattle area native and grew up in Mercer Island. And with that, I welcome Dr. Mammen to start, and he's going to tell us an update on myositis.
Yeah, thanks for the introduction. And yeah, I hope you guys eventually someday go back to in-person Grand Round, so I can have an excuse to come to Seattle and visit you guys in person. But today
we would love that.
by Zoom. And I think I spoke to your group, I can't remember, maybe 5 or 6 years ago, something like that. So I'm going to give you guys an update on autoimmune muscle diseases or myositis today. And in terms of disclosures, I usually mention that I am on a patent for this anti-HMG-CR autoantibody test, but I don't receive compensation for that since moving to the NIH. And the other thing is that I will discuss some off-label treatments for myositis, because as you know, there are very few FDA-approved treatments. So there are 4 major kind of themes that I want to talk about today. The first is going to be just explaining to you guys the 6 major types of myositis as I see it. Other people might see it a little bit differently. I'm going to tell you guys some things about myositis-specific autoantibodies and how they really help us define the different types of myositis. I'm going to present some new work on studies that we've done looking at muscle biopsies of patients with immune checkpoint inhibitor triggered myositis, which is an emerging type of myositis. In fact, some places that's the most common type of myositis consult people are getting, depending on your activity of your oncology center. And then if there's time, I want to tell you about some recent work that we've done showing, I think, that myositis-specific autoantibodies, at least the one I'm going to tell you about, may have a pathophysiologic role in myositis and maybe is not just a biomarker, but actually might have some important functional activity as well. So starting off, what are the 6 major types of myositis? And these first 2 slides are a little bit busy. I apologize about that, but I kind of wanted to give everyone sort of a broad overview of myositis. So on the left, we've got the first type, which is inclusion body myositis, or IBM. And all of these different types of myositis have characteristic muscle biopsy features. I'm not going to talk about the muscle biopsy features too much. We kind of give a whole talk on that, but I would say it's important to recognize that inclusion body myositis muscle biopsies are characterized by CD8 positive T cells surrounding and invading otherwise healthy looking muscle fibers. This is just an H&E, but if you did a CD8 stain, most of these would be CD8 positive T cells. And then they also have these vacuolar structures, which are called red rim vacuoles because they appear red on the Gamori trichrome stain. Here they're staining kind of purple. But when you see CD8 positive T cells surrounding a muscle fiber and the vacuoles together, that is pretty much diagnostic of inclusion body myositis from a histopathologic view. Now, either one of those things alone is not. You can have vacuoles without inflammation or inflammation without the vacuoles, and that's less diagnostic. And both are together, that's pretty characteristic. And in terms of the clinical features, of course, the main features are not just proximal muscle weakness. In fact, sometimes you don't have a lot of proximal muscle weakness like you do in all the other types of myositis I'm going to talk about. Instead, there is distal finger flexor weakness, which I think is the most important thing to look for when you're trying to evaluate a patient for inclusion body myositis. And this is a patient with extreme distal finger flexor weakness who can't fully sort of grip his fingertips in his palm here. But often it's more subtle and you have to look for it. Basically, I have patients grip my finger like this, and if I can peel off their distal fingers from my finger, then that's evidence of some weakness. They also characteristically have quadriceps weakness out of proportion to hip flexor weakness. And when it's pretty severe, you can see, just gross atrophy when you look at the patient here. And the other thing that I think these two pictures highlight is the asymmetry that's often seen clinically in patients with inclusion body myositis. You can see that the patient's right leg is more atrophic than the left, and the right distal finger flexors seem to be stronger than the left distal finger flexors. That's typical of inclusion body myositis and less typical of the other types of myositis I'm going to talk about. Now, I sort of spoke about inclusion body myositis in a little more detail than I'm going to talk about the rest of these forms of myositis up front here, because I'm not going to talk. I could give, again, a whole lecture on IBM, but I'm not going to say much more about inclusion body myositis for this talk. The second type of myositis, major type of dermatomyositis, or major type of myositis, is dermatomyositis, or DM. Muscle biopsies classically have perifascicular atrophy or perifascicular damage. This is a stain sort of at lowish power, and you can see that the muscle fibers are arranged in fascicles. And at the center of the fascicle, you have normal size myofibers, but on the edges, they're small. So that's the perifascicular atrophy that you see in dermatomyositis. I would mention you only see it in about 60% of dermatomyositis muscle biopsies. So if you don't see it, doesn't mean the patient doesn't have dermatomyositis. Of course, the skin features include heliotrope rash here. You can see these erythematous lesions over the upper eyelid, and also Gottrin sign or Gottrin papules, where you have these erythematous lesions over the extensor surfaces of the MCP, PIP, and DIP joints. Importantly, dermatomyositis patients have an increased risk of cancer, and we're going to talk about that in some detail later on in the presentation. And there are a certain set of myositis-specific autoantibodies that are found in dermatomyositis patients. I'll talk about these in a little more detail in later parts of the talk, but just to mention, the major, most common ones are antibodies recognizing Mi-2, TIF1 gamma, NXP-2, and MDA5. And these are all commercially available autoantibodies. So these are the antibodies we see most often in dermatomyositis patients. And then we've got the anti-synthetase syndrome. The anti-synthetase syndrome is, in my mind, really diagnosable in anyone who has an anti-synthetase autoantibody and has the right sort of clinical feature. So the most common clinical features are myositis, interstitial lung disease, and arthritis. So if you have one or more of those and one of these autoantibodies, that's usually good enough for most of us to consider the patient to have the anti-synthetase syndrome. Looking at the muscle biopsy features, it's not a mistake that I'm showing you the same picture for dermatomyositis and the anti-synthetase syndrome, because looking at the muscle biopsy, you can't tell the difference. Perifascicular atrophy or damage is common and seen about 60% or 70% of the anti-synthetase syndrome patients as well. Then, of course, they can have rashes that are very similar to dermatomyositis rashes in physical appearance, although sort of detailed transcriptomic analyses have demonstrated that they have different features at a transcriptomic level than what you see in dermatomyositis. And then interstitial lung disease is a major and sort of serious, potentially serious manifestation of the anti-synthetase syndrome, and arthritis as well. So not all patients have all of those features. Some do. Some have just a subset of them. And then I should also mention Raynaud's and fevers are also clinical manifestations that go along with the anti-synthetase syndrome. The fourth major type of myositis is necrotizing myositis, or immune-mediated necrotizing myopathy. As the name suggests, most of these patients have prominent myofiber necrosis on the muscle biopsy, and you can see some early and late-stage necrotic fibers. What you don't see is perifascicular atrophy. You don't see collections of lymphocytes surrounding and invading myofibers. You can sometimes see, in about 20% of these cases, perivascular inflammation. And so it's there is, even though we're calling them necrotizing, there are, lymphocytes in the muscle biopsies. And sometimes if you were to stain for CD8, you might see a few scattered CD8 positive T cells. I put a little wheelchair here because these patients tend to have the most severe muscle weakness of our myositis patients, with the exception of the late stage inclusion body myositis patients who can also be super weak. And then there are two myositis specific autoantibodies that go along with necrotizing myositis. The first is antibodies recognizing the signal recognition particle, or SRP. And then you have patients who have autoantibodies against HMG-CoA reductase, which is, of course, the pharmacologic target of statins. I think I failed to mention, although you guys probably know this, that the most common of the anti-synthetase syndrome autoantibodies is Jo1, whereas PL7, PL12, and EJ are less common. And I haven't even listed them all. There are now, I think, 10 different tRNA synthetases out of the total of 20, I believe, that are targets of the immune response in patients with the anti-synthetase syndrome. So those are the first four major types. And then you've got overlap myositis, which is really a heterogeneous group, I should say. I'm calling it a major type, but it's really a lot of different subtypes. On muscle biopsy, they can have myofiber necrosis or perifascicular atrophy or perifascicular damage. It kind of depends what is the overlapping connective tissue disease that they have. So the overlap myositis is really defined by the presence of myositis in a patient with a defined diagnosis of another connective tissue disease like scleroderma, lupus, or rheumatoid arthritis. And they can have myositis-associated autoantibodies, like autoantibodies recognizing RNP, PMSCL, or COO. And so each of these is really different. They have different muscle biopsy features, different clinical features, but I sort of put them as one category here. And then finally, kind of the new kid on the block is the immune checkpoint inhibitor triggered myositis. And those patients, we'll talk more about that later, these patients can have either myofiber necrosis or really inflammatory muscle biopsies with lots of macrophages. And many of these patients who get myositis also have other systems targeted. So it's not uncommon to have myositis with myocarditis or myositis with myasthenia gravis. And sometimes all three of these clinical features, the myositis, the myasthenia, and the myocarditis, can be seen together in the same patient. And that is especially severe and life-threatening. And we'll talk about that as the talk goes on as well. Of course, these patients have an increased prevalence of cancer. And many of these patients, even if they just have muscle involvement and not myasthenia gravis, many of them that we've seen have anti-acetylcholine receptor autoantibodies, which is not typically something you think of as a myositis autoantibody, but you can see it in these patients. So those are the 6 major types of myositis. You may be asking now, well, what happened to polymyositis? I thought there was dermatomyositis and polymyositis. I think most of us today kind of agree with this editorial that was written 20 years ago by Tony Amato and Robert Griggs, who are some prominent neuromuscular neurologists, who titled their editorial "Unicorns, Dragons, Polymyositis, and Other Mythological Beasts." So they were really claiming, boy, if it is out there at all, polymyositis is super rare. And I think most of us probably agree with that now, and would say that most of the cases that in the past would have been diagnosed as polymyositis probably have something else. So inclusion body myositis is probably the disease that's most commonly misdiagnosed as polymyositis. We see it almost every day in the clinic that we see new patients. Patients that have immune-mediated necrotizing myopathy would have been called polymyositis in the past, but now we think of them as having a distinct separate disease. Similarly, anti-synthetase syndrome patients who did not have a rash would have been called polymyositis. Today, many of us just consider all patients with the anti-synthetase autoantibodies to have the anti-synthetase syndrome for a variety of reasons, and we wouldn't consider anti-synthetase syndrome without a rash to be polymyositis. Then there's overlap myositis. Many of those patients were called polymyositis. And then another important category are patients with inherited muscle disease. I'm not going to get into this in too much detail, but there are a number of relatively common limb girdle muscular dystrophies that have significant inflammation on the muscle biopsy and can be misdiagnosed as polymyositis. In fact, one of the more common types of dystrophy is one called dysferlinopathy due to mutations in the dysferlin gene. And 30 to 40% of patients, at least 15 years ago, with that disease were diagnosed initially with polymyositis and sometimes treated for years or decades before they were recognized. And nowadays, it's pretty easy for us to look for many types of genetic muscle disease. So we don't make this mistake as often. You know, you can send out a gene panel looking for a couple hundred, genetic, muscle diseases and get the results back in 2 or 3 weeks commercially. So it's much easier to not make this mistake. But anyway, when I would say that a patient is diagnosed with polymyositis, or I'm thinking maybe this patient has polymyositis, in my mind, it means I really don't know what disease they have. I haven't figured it out yet. So that's where I'll leave you with polymyositis. So I want to just talk a bit in more detail about myositis-specific autoantibodies. And the main theme here is that each one is associated with a distinct clinical phenotype. And the first sort of clinical manifestation I want to mention is cancer. Each of the different myositis-specific autoantibodies is associated with a different risk of accompanying malignancy in patients with myositis. It's been known for a long time that myositis is associated with an increased risk of malignancy, but now we know how the MSAs, that were myositis-specific antibodies, correlate with that. And there's a lot of data out there about this. I'm just going to share with you the work done by Chris Meckley using the Hopkins cohort. He did a really nice study looking at over 1,100 patients that were seen at the Johns Hopkins Myositis Center, and he went back and did systematic cancer ascertainment, calling up patients, digging up old records and stuff, and also doing on all of those comprehensive autoantibody testing. And basically, he was trying to calculate the standardized prevalence ratio for each of these myositis-specific autoantibodies, which is defined as the number of observed cancers in the myositis patients divided by the expected number of cancers in the general population. That's basically how he did it. And what he found was what I think many papers had previously shown, which is that dermatomyositis patients with anti-TIF1 gamma autoantibodies have the highest risk of malignancy. It's got a standardized prevalence ratio of 3.5. Anti-NXP-2, anti-SAE, and anti-Mi-2 positive dermatomyositis patients have still an increased risk of malignancy, but not as high as TIF1. And then for all the other myositis autoantibodies that they looked at, including MDA5, which is also dermatomyositis, and SRP and HMGCR and the anti-synthetases, these had minimal, if any, increased risk of malignancy. And so, so this is sort of, I think, the first broad way in which the myositis-specific autoantibodies can help us. And you might be more inclined to do more aggressive cancer screening in these patients with a high standardized prevalence ratio compared to these other patients. And then he also looked at what types of cancer were most common, and ovarian cancer, oropharyngeal cancer, and then breast cancer were the most common types of cancer that were seen in these patients. So now, in terms of the individual antibodies, they in addition to the differences in cancer risk, they have different clinical manifestations. So compared to other DM patients with anti-NXP-2 antibodies are more likely to have subcutaneous edema. We said it was 36% versus 19% in our original description of this a few years ago, but now that we're looking for it, subcutaneous edema is probably more common than that in NXP-2 positive DM cases. Here's a pretty marked example of that. Is somebody who has forearm edema with really pitting edema in the forearm that's due to the myositis. There's no other explanation for this. And often it can be seen in just upper extremities or just lower extremities or sometimes both. The other thing that we see in the NXP-2 patients that we described is increased prevalence of distal arm weakness and distal leg weakness. So specifically, finger extensors and ankle dorsiflexors have increased rates of weakness. And again, this 35% is really a gross underestimate, we now realize, of how much finger extensor weakness there is in these patients. Often the finger extensor weakness is pretty significant. Like this patient here can't even fully extend their fingers. But often it's more subtle, but you can push down and see that the finger extensors are weak. And for reasons I don't understand, that can be the last thing to get better. All their proximal muscle weakness will get better, but it might be a year before their finger extensors get better when you treat them. About 2/3 of these patients have dysphagia. Calcinosis, which is sort of a dreaded cutaneous manifestation of DM, is increased in anti-NXP-2 patients compared to other types of dermatomyositis. And again, as I pointed out previously, these patients have a moderately increased risk of cancer. Anti-Mi-2 positive dermatomyositis patients, they have the typical skin manifestations of DM. Among all our DM patients, these are the ones who are the weakest. They have the most severe weakness on presentation, and they have the highest CK values because they have a lot of inflammation and necrosis on muscle biopsy. So in the Hopkins cohort, among the anti-Mi-2 positive DM patients, the mean max CK was close to 4,000, much lower in those who had other types of dermatomyositis without Mi-2 antibodies, where the CK on average is just moderately elevated at 242, although there is a big range. As I said, they have the most inflammation on muscle biopsy. The good news is that these patients tend to respond pretty well to treatment, and the skin and muscle disease can sometimes go into complete remission. And I'm not showing you the data here, but we have shown that in the patients who, after years of treatment, go into remission, you actually lose the anti-Mi-2 autoantibodies, and that's different than some other types of myositis. Again, these patients have just a moderately increased risk of malignancy. These are some pictures of skin manifestations of people with anti-MDA5 antibodies. And you can tell these patients when they come into your clinic, because instead of just having the finger extensor or extensor surface skin manifestations, they're going to have lesions on their palms. And this is an example of an ulcerating lesion on the palmar surface. Here's another one. They may also have Gottrons for sure, often ulcerating, but really the characteristic thing are these palmar skin manifestations. So we look for that clinically, and you can often just predict this is going to be an MDA5 positive patient. The other thing that they have a lot of is interstitial lung disease. So the anti-MDA5 patients, they can often, more frequently than other types of dermatomyositis, have severe and rapidly progressive interstitial lung disease. And that's especially true in the Asian population, where the mortality rate for this can be up to 60%. Now, in contrast to the severe ILD, often anti-MDA5 patients have minimal or no muscle involvement. So they may just present with interstitial lung disease and maybe skin manifestations and may not have weakness at all. These patients have minimal, if any, cancer risk. I actually think, in my humble opinion, MDA5 people are going to think of as a distinct disease. It's like somewhere between the anti-synthetase syndrome and the other dermatomyositis patients that we see. One thing I think is good to know about is that, and this is some work from a group that sees a lot of MDA5 patients. They had a lot of historical controls, and they could see in the first 6 months, about 20% of their patients died who had MDA5 and rapidly progressive interstitial lung disease. These were treated very aggressively. The main difference between their historical controls and the patients they included in this study was early adding tofacitinib, a JAK-STAT inhibitor. So in the JAK-STAT inhibitor treated patients, none of the patients died in the first 6 months. So this was pretty dramatic, and I believe that there is an ongoing double-blind clinical trial of this. But most of the clinicians I know, if they see an MDA5 patient with rapidly progressive interstitial lung disease, a JAK-STAT inhibitor is going to be considered early on. The next one are anti-TIF1 gamma autoantibodies. These ones, as I mentioned earlier, have the most substantially increased risk of malignancy. They have typical dermatomyositis skin features, symmetric proximal muscle weakness like the other DM, sort of classic DM patients. But really the thing is this increased risk of malignancy is the main thing to keep in mind. So you definitely want to screen your DM patients for these antibodies to sort of risk stratify them. So one thing I should mention, or should have mentioned probably at the beginning, is only about 70% of dermatomyositis patients have a myositis-specific autoantibody that we can identify. And we were really interested in whether we could find novel dermatomyositis specific autoantibodies. And we collaborated with a guy named Ben Larman at Hopkins, who helped develop this tool called phage immunoprecipitation sequencing, or FIPSI, to identify novel autoantibodies. And I'm not going to go into the details of this technique, but what's cool about it is they basically make a library that spans the whole human proteome. The library consists of overlapping tiled peptides, and they express all those peptides on bacteriophage. So each bacteriophage is only expressing one of these peptides. And then you use patient serum to immunoprecipitate the phage, and then you can do sequencing to identify what peptides are being recognized by the antibodies. And so we worked with Ben to look for novel myositis-specific autoantibodies in DM patients. And so we started this by using serum from 43 DM patients, many of which didn't have a previously known myositis-specific autoantibody. And we found that there was reactivity against a protein called SP4, which is a transcription factor. And then after we used FIPSI, we developed an ELISA test to sort of rapidly screen through our patients. And we screened serum from 371 myositis patients, 80 disease controls with lupus, Sjogren's, or rheumatoid arthritis. And what we found is that these are the anti-SP4 titer. Anti-SP4 autoantibodies are really only found in myositis patients. They're only found in dermatomyositis patients. And the other interesting thing that at first didn't seem very exciting is that all of the patients with dermatomyositis who were anti-SP4 positive were also positive for anti-TIF1 gamma. So our initial thought was, oh, this isn't that exciting. You know, anti-SP4 just identifies kind of a subset of anti-TIF1 gamma patients. And when we looked at their clinical features, we didn't really find anything that was especially exciting about those patients until we looked at malignancy. And what we found is that the anti-SP4 autoantibodies are found in the TIF1 gamma patients who don't get cancer, right? So anti-TIF1, very high risk of malignancy. But if you also have anti-SP4, you don't have that increased risk of malignancy. So it identifies a subpopulation of the TIF1 gamma patients who aren't at risk for increased malignancy. So and it may be those patients don't require the same degree of aggressive cancer screening that we do for our other dermatomyositis patients, especially the TIF1 gamma positive ones. So what's the relationship now, do we think, between cancer, autoantibodies, and dermatomyositis? And this is something that we and others have thought a lot about. Anthony Rosen at Hopkins, I think, has thought about this maybe the longest. And I think he might have been one of the early people to come up with this sort of idea that tumors precipitate an anti-tumor response that includes humoral autoantibody against targets like TIF1. And that these TIF1 autoantibodies might actually elicit dermatomyositis, but that immune response is not sufficient to eradicate the tumor. So you see tumor, you see dermatomyositis, and you see TIF1 autoantibodies. On the other hand, if you develop a stronger immune response, we'll call it stronger, that includes both anti-TIF1 and anti-SP4 immunoreactivity, you get dermatomyositis because of those antibodies, but that immune response is strong enough to eradicate the tumor. So that's sort of the hypothesis, unproven, but that's sort of currently how we are thinking about it, and are looking to determine whether that's actually the case or not. So I just wanted to spend a couple minutes talking about what's new for the treatment of dermatomyositis. I thought it's really important to mention a couple new things. The first is that Rohit Aggarwal, spearheaded this very large placebo-controlled trial of IVIG in dermatomyositis patients. And he was really able to prove, kind of beyond a shadow of a doubt, that IVIG leads to clinical improvement in patients with dermatomyositis compared to their placebo group. And so, so this was a really nice design. I think most of us already knew IVIG worked for dermatomyositis, but now it has an FDA-approved indication in dermatomyositis, which I think is very good for patients. Another thing I would be remiss not to mention is that JAK and STAT inhibitors, based on cases and case series, seem to be promising for dermatomyositis. And I just show you some various examples here of recently published cases and case series of patients who had refractory dermatomyositis, both adults and children, who really improved with JAK inhibitors. And just anecdotally, what I can tell you is that in terms of calcinosis, JAK-STAT inhibitors are really the only thing that I've seen that has really stopped calcinosis dead in its tracks. I think we need to do better studies of that, but I will often go to a JAK-STAT inhibitor in patients who develop calcinosis. So something to keep in mind. All right, a little bit about anti-synthetase syndrome. These, again, are the classic clinical manifestations: the myositis, arthritis, ILD, mechanics hands, which are these hyperkeratotic lesions on the radial surfaces of the fingers, skin rashes, DM-like skin rashes, and Raynaud's phenomenon, and then fevers as well. And of course, some patients have all of these, some patients have some of these features, but those are the typical manifestations of this disease. What's new for treatment of the anti-synthetase syndrome? So what I should say is that we treat, all these patients with often steroids, then oral agents like mycophenolate, azathioprine, methotrexate, and then sort of, our third line agents, although we tend to use a more second line, would be IVIG and rituximab. But despite treatment with various combinations of those sort of standard therapies, there are some anti-synthetase syndrome patients who are just refractory lung and or muscle disease. And there have been a number of case reports in the last year or so demonstrating that a few of these very refractory anti-synthetase syndrome patients have responded very well to CD19 targeted CAR T cell therapy. And so here you can see, patients after they get the CD19 CAR T therapy, the sort of physician and patient indices of disease activity go way down. The muscle strength, which started low, goes up. The CK, which was 6,000, goes to normal by 3 months after the CD19 CAR T therapy. And then the anti-Jo1 autoantibodies go from very high titer to non-detectable. So this is, these kinds of studies are really interesting. And I'm hopeful that there will be clinical trials to really demonstrate how effective this is in a larger group of patients. And here are just a couple other examples, again, of patients or of examples of patients who responded really well to CD19 targeting CAR T cells when they failed a lot of other things. So that, I think, is on the horizon. What about immune-mediated necrotizing myopathy? I'll take a few minutes to bring you up to date on that. So anti-HMGCR myopathy is the most common. Muscle biopsies, like I said before, are necrotizing, although 20% will have some inflammatory cell infiltrate, mostly perivascular. Almost all of them have proximal muscle weakness. Most of them have muscle pain. They have very high CK levels. The mean max in our cohort's about 10,000. These patients, unlike many of the other types of myositis, have minimal extramuscular manifestations. So they don't get ILD, they don't get arthritis. There may or may not be some skin manifestations in some people. We're trying to work that out, but it's not usually a classic DM rash, that's for sure. And then importantly, in the United States, about 70% of these patients overall have had a statin exposure. And the patients who have this disease over the age of 60, it's about 95% have had a statin exposure. That being said, only about 1 in 50,000 statin users will develop anti-HMGCR myopathy. Importantly, even though the disease seems to be triggered by statins, it doesn't end when you stop the statins in most cases. It usually takes on a life of its own that needs to be treated with immunosuppressive therapy. And if you re-challenge patients with statins, they can have a flare of their disease. So we don't usually treat them with statins. In addition to the statin trigger, there are other risk factors for developing anti-HMGCR myopathy. Lisa Christopher Stein and her collaborators found that type 2 diabetes is enriched in patients with anti-HMGCR myositis compared to other statin-exposed myositis patients who don't have anti-HMGCR antibodies. And also, she found that atorvastatin seems to be more tightly linked to developing anti-HMGCR myopathy than patients who've been exposed to rosuvastatin or simvastatin. So these are intriguing results that I think need to be confirmed in other cohorts. But I think for those of you who see these anti-HMGCR patients, so many of them have type 2 diabetes that predate their use of statins that really does seem for sure to be some kind of a risk factor. We also know there are genetic risk factors. I won't get into this work in too much detail, other than to mention that there's a specific class 2 HLA allele called DRB11101 that is only found in 10 to 20% of the general population, that's found in 70 to 90% of patients with anti-HMGCR myopathy. And DRB11101 turns out is one of the most one of the strongest immunogenetic risk factors for an autoimmune disease. Still, even among those who have HLA-DR11, the risk of developing anti-HMGCR myositis is low. It's about 1 in 10,000. Now, those numbers are all from Black and white patients in our cohort and in other people's cohorts. Interestingly, what we found recently, or I should say my colleagues on the Navajo reservation out in Gallup, New Mexico, I worked on this with them, but they really were the ones who figured this out. They found that out of 5,000 patients on the reservation who were treated with statins, 14 developed anti-HMGCR myopathy. So about 1 in 300 statin-treated Navajo developed anti-HMGCR myopathy. And that is about 150-fold increased risk in the American Indian patients there on that reservation compared to white and Black patients in the rest of the United States. And my colleague, Lisa Christopher Stein, working with her colleagues on the Apache reservation that's nearby, found exactly the same phenomenon. So for some reason, this patient population is at increased risk. And I would hazard a guess that it is due to some immunogen or some kind of genetic risk factor. And we'd love to figure out what that is, but there are real obstacles in terms of doing genetic research in these populations. So still working on that. But that's something to keep in mind. If you, we haven't looked at Pacific Northwest Indians, so you might guys keep an eye out for that. How do we treat anti-HMGCR myopathy? Well, relatively early on, we realized when we treated patients with this type of disease with methotrexate and prednisone, often they wouldn't get very much better. We'd add IVIG, and boom, they would get better pretty quickly. So we treated 3 anti-HMGCR patients with IVIG as monotherapy, and all 3 of them really improved dramatically. So after 1.5 to 3.5 months, the mean CK went from almost 5,000 to just over 1,000. Arm abductors and hip flexors got better, and that was sustained after 9 to 19 months. So we've been using IVIG a lot in this patient population. And recently, Dr. Agarwal, again, Rohit Agarwal at University of Pittsburgh, published this paper looking at IVIG in necrotizing autoimmune myopathy, including mostly anti-HMGCR patients. And what he found is in these refractory patients, adding IVIG led to really dramatic improvements in CK levels and improvements in muscle strength as well. So based on pre-existing data now reinforced by the data from Dr. Agarwal's group, the treatment recommendations from the European Neuromuscular Center include using IVIG early in anti-HMGCR myopathy cases, possibly as monotherapy or potentially also with some other agents as well. I'm not going to get into the data around these recommendations, but in contrast to HMGCR, in patients with anti-SRP, this group recommended the early use of rituximab, and that's definitely what we do in our clinic, is use rituximab early in anti-SRP patients. What about managing hypercholesterolemia in these patients? So they're, presumably many of them are put on on statin therapy for a reason. Can we still manage that? So turns out you probably can't safely use statins, but PCSK9 inhibitors seem to be well tolerated. And this is work done by Eleni Tiniakou and the rest of the Hopkins Myositis Center group. And they, a couple years now ago, showed that among 8 anti-HMGCR patients who were started on PCSK9 inhibitors, followed for more than a year, there's no reduction in strength and no increase in CK levels. In fact, the CK levels continued to go down. And now we've treated many more patients with PCSK9 inhibitors who also have anti-HMGCR antibodies, and we have not seen disease flares triggered by PCSK9 inhibitors. So that's something to keep in mind. Anti-SRP, the anti-SRP phenotype also has a necrotizing muscle biopsy. You can't tell the difference between SRP and HMGCR by looking at the muscle tissue. These patients often have rapidly progressive severe weakness, also CK levels around 10,000. And although many of these patients just have muscle disease, there is extramuscular activity in some of them. So there's mild ILD, if you look for it, in about 20% of SRP patients. A few of them will have dermatomyositis rashes, and depending on what clinic you're looking at, maybe 5 to 10% will have cardiomyopathy. So these patients, more than the HMGCR patients, have extramuscular manifestations. These are among our most difficult to treat patients, and as I mentioned just a minute ago, we often will use rituximab early in these patients. The last type of immune-mediated necrotizing myopathy is antibody-negative immune-mediated necrotizing myopathy. So these are patients who don't have SRP or HMGCR antibodies, but have a necrotizing muscle biopsy. And compared to patients with SRP or HMGCR antibodies, there was a female predominance in those who were antibody negative. They were more likely to have an associated connective tissue disorder like lupus or RA or scleroderma. And just overall, they had higher rates of extramuscular disease activity compared to patients with SRP and HMGCR. So I wanted to spend a minute just talking about how we, these days, diagnose patients with the different types of immune-mediated necrotizing myopathy. Again, there are 3 types: HMGCR, SRP, and antibody negative. And to diagnose anti-HMGCR myopathy, the ENMC recommendations suggest you just have to have proximal muscle weakness, a high CK, usually over 1,000, and anti-HMGCR autoantibodies. You don't need to confirm the diagnosis by muscle biopsy. Similarly, for patients with proximal muscle weakness, a high CK, again, usually over 1,000, and anti-SRP autoantibodies, that's generally good enough in most cases to diagnose the disease, and a muscle biopsy isn't required. It is a different story for immune-mediated necrotizing myopathy that's antibody negative. To get that diagnosis, antibody negative IMNM, you have to have the proximal muscle weakness and a high CK. You also have to show there are no myositis-specific autoantibodies and that they have a necrotizing muscle biopsy. And this is really important, that they have no myositis-specific autoantibodies and the necrotizing muscle biopsy, because the necrotizing muscle biopsy itself is not diagnostic of immune-mediated necrotizing myopathy. In fact, as this recent paper showed, in JO1 patients, antisynthetase patients, the most common histologic pattern is a necrotizing pattern. About 38% have prominent myofiber necrosis. You see an inflammatory pattern in 35% and a non-specific pattern in about 27%. So necrotizing muscle biopsy does not equal IMNM. You also have to have no myositis-specific autoantibodies. All right, so this is probably the last topic I'm going to have time to talk about today, and that is immune checkpoint inhibitor triggered myositis. Fortunately, it's relatively rare. It only occurs in about 1% of patients that are treated with checkpoint inhibitors, and the presentation is kind of heterogeneous. So many will have proximal muscle weakness. Unlike other myositis patients, many of them will have ptosis and/or double vision, even without evidence of a neuromuscular junction defect on repetitive stimulation testing or single fiber EMG, right? So those are characteristic features of myasthenia without the electrophysiologic hallmarks of myasthenia. Some of them, although a minority, will have dermatomyositis skin rashes. their muscle biopsy findings have been described sort of as a heterogeneous group, with both patients who have predominantly inflammatory muscle biopsies and other patients who have prominent myofiber necrosis. Similarly, CK elevations can be mild to super high over 10,000. And as I mentioned at the beginning, patients can have not just myositis, but also myasthenia, about 12%, and or myocarditis, about 11%. And these two can co-occur together. If you have myositis and myasthenia gravis, about half of those patients are going to require ventilatory support. So those patients are pretty severe. And in patients who have myocarditis, there's about a 60% fatality rate, or at least there was when I last looked up the data. Now, the treatments, we don't really know what the best treatments are. In general, what people do is to stop the immune checkpoint inhibitor and initiate some sort of immunosuppressive therapy with steroids or other agents. So we were really interested in looking at muscle biopsies from patients with checkpoint inhibitor myositis and doing transcriptomic analyses and comparing them to our patients with other types of myositis. We've done this for a lot of different types of myositis. So this analysis I'm going to tell you about includes 200 muscle biopsies, including 35 patients with immune checkpoint inhibitor myositis. So about those 35 patients, they got both PD-1 inhibitors and PD-L1 inhibitors, or I should say, and/or. The most prevalent tumors in this group of 30-some that we studied were melanoma, thymoma, and lung cancer. 20% of them had double vision, and then more than a third developed myocarditis. About 40% had autoantibodies against acetylcholine receptor antibody, and a few patients, just 3 out of the 35, had dermatomyositis rashes and anti-TIF1 gamma autoantibodies. And what we did is to do bulk RNA-seq, define the gene expression profiles of each patient, and do clustering analysis, grouping patients together who had similar transcriptomic features. And so this is the unsupervised clustering results. And what we saw is that there were 3 absolutely transcriptomically distinct populations of patients, in this larger group. And we named them ICI Myo1, all these red dots clustered together, ICI Myo2, these green dots, and then here are the 3 dermatomyositis patients, totally distinguishable based just on transcriptomic data. And one of the first things we recognized is that clinically these patients were different, not just transcriptomically. So you had your dermatomyositis patients, but also only the patients in this red group, the ICI Myo1, developed myocarditis. So all of the myocarditis occurs in this group. In this ICI Myo2 group, there's no myocarditis. So that was pretty striking. Then we look at the muscle biopsies, and what we saw, I'm not going to go into this in great detail given our time, but the ICI dermatomyositis patients had typical dermatomyositis muscle biopsies with perifascicular atrophy and upregulation of type 1 interferon regulated genes. In contrast, the ICI Myo1 patients, these are the ones who get myocarditis, they had highly inflammatory muscle biopsies with lots of macrophages. And then the ICI Myo2 patients who never get myocarditis, as far as we've seen, they had necrotizing muscle biopsies, right? And low levels of type 1 interferon upregulated genes. So they were not just different transcriptomically, they were different on muscle biopsy. And now I'm going to show you just a little bit of the more detailed transcriptomic data. So here we're looking at the expression of type 1 interferon inducible genes, IFIT1, MX2, and a couple others. And here, blue means low expression and red means high expression. And what we can see is in classic DM, there's a high level of type 1 interferon inducible genes, much lower in the other types of myositis. And that held true for the patients who were treated with immune checkpoint inhibitors who developed TIF1 gamma positive DM. So these two look pretty similar in terms of the type 1 pattern. When we looked at type 2 interferon inducible genes, now we're looking at GBP1, GBP2, other type 2 specific interferon inducible genes. What you see is, it's a little bit high in our patients with DM, antisynthetase syndrome, and IBM. It is really high in the ICI dermatomyositis patients And it's also high only in the ICI MYO1 patients. So these patients in the ICI MYO1 group, the group who gets myocarditis, they have a lot of induction of type 2 interferon-inducible genes in their muscle biopsies. And then doing pathway analysis, what we found is that patients with any form of immune checkpoint inhibitor myositis had upregulation of interleukin-6 pathway genes. So you never see these, you don't see these genes upregulated in classic DM, anti-synthetase syndrome, IBM, IMNM, but they're highly expressed in all the different types of immune checkpoint inhibitor myositis. So just to sort of summarize the findings there, there are 3 transcriptomically distinct types of immune checkpoint inhibitor myositis. Only the ICI MYO1 group gets myocarditis, so maybe we need to treat those patients more aggressively. And also the interleukin-6 pathway is overexpressed in all 3 types. And other groups, for other reasons, have thought that tocilizumab, an interleukin-6 receptor blocker, might be a good treatment, and our data would support that as well. So I think I'm running up against my time limit, so I'm not going to really talk about this data, which I think is pretty enticing, showing that we think myositis autoantibodies might be pathogenic. I'm going to be, if you're interested, I'm going to be giving a talk about this, and my colleague Iago Pinal Fernandez will be giving a talk about this at the ACR coming up in November. So I'm just going to leave you with a little teaser that we have data that the antibodies might be pathogenic. And just to sort of cut to my final sort of main new concept slide that I just want to leave you with. Again, we think there are 6 major types of myositis, which I've talked about. American Indians exposed to statins are at high risk of developing anti-HMG-CR myopathies, about 1 in 300. Myositis-specific autoantibody profiles can be used to accurately stratify myositis patients for risk of cancer. The TIF1 gamma DM patients are most at risk, and now we've identified another autoantibody that tells us which of the TIF1 gamma patients are not at increased risk, and we hope that that will be made commercially available at some point in the future. I hope I've convinced you that there are 3 distinct types of immune checkpoint inhibitor triggered myositis. A few patients just have sort of really jazzed up dermatomyositis, but then there are patients who are especially at risk of myocarditis, who have very high upregulation of type 2 interferon genes. So I will leave it at that, and leave myself a few minutes to answer any questions that might be out there. So thank you guys very much for your patience.
Thank you, Dr. Mammen. That was excellent. And I was hoping to hear about the pathological role, but maybe
There's also, we also have a paper in Annals of Rheumatic Disease. So if you type up Mammen Mi-2, you'll probably can find that paper. But otherwise, yep, it's just a teaser at this point.
Okay. I think actually I've seen that paper, but yeah. Okay, we have multiple questions.
Okay.
There is a question about tofacitinib and whether you think this is replacing cyclophosphamide and tacrolimus as an first-line therapy in MDA5 myositis.
Yeah, that's a great question. So all the data is not in, but we're certainly using it a lot more. And I think it's a very potent medication for these diseases. There's concern about the side effect profile, I must say, and long-term use of those medications. So I think we're all hoping that some of the newer, more selective JAK inhibitors might be give us the same beneficial effect without us being so worried about some of the potential side effects of tofacitinib. But I do think that pathway, the interferon pathway, specifically targeting that either with those drugs or other drugs that may be coming online, are going to be super effective in antisynthetase and dermatomyositis in particular, maybe not so much IMNM.
Yeah. And we have a question about, this is a kind of specific question. We have a TIF1 gamma DM patient with breast cancer who had resection and have severe periorbital swelling on IVIG for 3 months. And it's not improving. Do you have any recommendations in this case?
Yeah, so I mean, it's hard for me to offer very specific recommendations with such a brief sort of clinical picture, but I think many of us would go to rituximab as a next option in a patient with severe kind of refractory dermatomyositis. We would often leave, if we thought we got some benefit out of the IVIG, we might leave them on the IVIG and give them rituximab. Tofacitinib, as the first question, as came up earlier, is another thing one might consider giving in that situation. Tofa, I think, tends to act more quickly than rituximab, which would be maybe one reason to use that if you can get it. But those are tough questions, and we don't have like data-driven answers to them.
And in terms of using IVIG for DM,
Yep.
What kind of patients would you give that to?
Yeah, so that's a good question. So in my own practice, patients who are having difficulty ambulating or have dysphagia, I will almost always include IVIG as part of my initial therapy. And patients who like just have a little bit of a rash, probably not. I'm probably going to maybe start mycophenolate or something possibly with some steroids. So everything, of course, like all the diseases, rheumatic diseases you guys treat, right? It's tuned to how severe the presentation is. But IVIG is definitely something in my armamentarium, and I like it because it works pretty quickly. So it's going to work more quickly than like mycophenolate, for example. So again, hard for me to really specifically answer that question, but I definitely use it early in people who are severe, sometimes just right away. And in milder patients who aren't responding to other things quickly enough, it's one of my go-to medications for sure.
And this is a question on the ICI myositis. Dr. Singh is asking, wondering if it mattered at all what their ICI therapy was PD-1 versus CTLA-4?
Yeah, so it seemed we didn't really see a difference in terms of what type of myositis the patients had, although our numbers are relatively small. But both patients but the ones that we saw were mostly PD-1 or PD-L1. There were some CTLA-4 patients in there. I don't think we have that as well defined yet.
Okay. Lots of questions about MDA5, people like that.
Yeah.
So in terms of the MDA5 ILD,
yeah.
So there are two questions that I'll ask them as a group.
Yeah.
One is, what would be your first treatment for MDA5 ILD? And the other one is there a difficulty in getting insurance to pay for JAK inhibitors?
Yeah, so I'll preface this by my caveat, which I should have put that in there, my disclosures on my second slide, which is I am a neurologist. So I tend to lean heavily on my pulmonary colleagues, particularly Sonia Danoff at Hopkins, for patients with interstitial lung disease. Having said that, full disclosure on my non-expertise in pulmonary disease, tofacitinib, we tend to use early in patients with ILD, and I personally haven't been trying to get it for that indication, so I don't know how difficult it is to get for that. I certainly know that I have to battle to get it for DM patients with significant skin and or muscle disease. Sometimes it's easy and sometimes it's hard. I imagine it might be the same for the patients who have severe interstitial lung disease. But again, I don't have personal experience getting it for that indication.
And let's do one question in basic science. Dr. Mustian is asking, what antigens are T cells recognizing in myositis?
Yeah, so that's a great question, and all I can tell you is that we don't know for sure. People are trying to investigate this. I think there's good evidence. Well, I think there's emerging evidence that there are T cells that, for example, there are CD4 positive cells that recognize HMGCR, and we know this at least for class 2. You can immunoprecipitate class 2 HLA alleles from the antigen presenting cells and elute off MHCR peptides, but this is pretty early days in us figuring that out. And in general, we don't know what the targets of the T cells are. My personal I don't know, belief is a strong word. My hunch is that the T cells are really important in inclusion body myositis, and the CD8 positive T cells may be less drivers in the other types of myositis, where I think I'm beginning to believe that the antibodies might be more important, that the humoral response might be more important. But that, of course, we could debate about, and nobody knows the right answer for sure.
Okay, another question from Dr. Wenner asking about what do you think of the associations of some autoantibodies with ILD?
Don't know.
Okay.
Yeah, so that's a great question. So even in patient like we have some data that like anti-Mi-2 autoantibodies enter muscle cells, bind to their target, and have functional effects. I don't have corresponding data or theories about how that works in skin or lung.
Yeah.
So
that's
a big gaping hole in my theory.
Yeah. Okay. Yeah. I guess another example that people usually think of is the anti-Rho52, and that it's associated with ILD, right?
Yeah, that's true. Jo1 patients who have Rho52 are more likely to have ILD. One thing I would point out is that would sort of I think strengthen the argument for the humoral response being important is in those patients who had refractory interstitial lung disease who were treated with anti-CD19 CAR T therapy that wipes out B cells, specifically B cells, right? Those patients, their Jo1 titers went to normal and their interstitial lung disease got a lot better. So in my mind, that's kind of a additional supporting evidence that somehow it is the humoral response. Although, of course, B cells might have other functions that might account for the improvement. Another little just factoid that I wanted to mention, I should have put it in my talk, is that I've always wondered whether the anti-HMGCR autoantibodies might be pathogenic by binding and inhibiting HMGCR just like a statin does, right? So you might think, okay, statins can cause myotoxicity by binding to HMGCR, inhibiting it, and maybe the anti-HMGCR autoantibodies do the same thing. And the really cool new thing there is that in the past year, a group in Israel described patients who have mutations in HMGCR that wipe out its functionality. So it's like 95% decreased HMGCR activity. And the only clinical manifestation in those families is limb girdle muscular dystrophy. So if you inhibit HMGCR, if you knock out HMGCR, you instead of getting widespread tissue dysfunction, it's just muscle, and they get a dystrophy that looks like anti-HMGCR myopathy. So again, that's like additional little clues in my mind that are pointing to the antibodies potentially being pathogenic. Of course, we got to prove that the antibodies bind and inhibit HMGCR and cause damage, but that's kind of the framework in which I think about these things.
That's super interesting. Okay, another question. This is on CAR T cell, and I'm going to add another question to this. For the CAR T cells, these studies that you showed, I think all had no controls.
No controls and conditioning, right? So that's the thing that people often bring up, that there is the conditioning that goes on before the CAR T therapy. And so, so I should have mentioned that. That's an open question about to what extent that conditioning therapy, which includes, I think, cyclophosphamide and some other agent, I'm just forgetting the name of.
Yes, but it's very aggressive.
Strongly immunosuppressive agents. And some people are saying, hey, wait a minute, maybe it has nothing to do with the CAR T therapy. It's that. And that's an excellent point. So I think we're, that is something that is definitely true, and a definite question mark about what the mechanism is for those patients.
And the question from Dr. Carr regarding CAR T cells is, are there any specific antibody therapies being studied?
So, I think what you might be talking, I think maybe what you're talking about is CAR T therapy directed to something other than CD19. Like, for example, there are CAR T therapies where you're targeting not B cells, but a specific plasma cell that's expressing a specific type of antibody on its surface. So basically, you have the CAR T cell, and the bait is the antigen, right? So you might have Jo-1 protein, and it's going to engage with B cells that are making antibodies against Jo-1 and wiping those out. There are people working on that. You guys might be aware that in pemphigus, in mice, Amy Payne has shown that she can, in pemphigus, it's an antibody-mediated disease. They know the target, and they have constructed CAR T cells that express that antigen. And in mice, they can effectively wipe out pemphigus by destroying the B cell population. But I don't know that that's ever been tried in humans. It hasn't been tried for any myositis antigens, but I definitely have talked to people who are working on that. One of the challenges is that it's very challenging to get a cytoplasmic protein expressed extracellularly on the CAR T platform. Okay. Yeah. Anyway.
I see. Okay, another question from Dr. Stoltz. Have you compared ICI myositis to other ICI adverse events, such as arthritis or thyroiditis? And are these expression profiles similar?
Great question. No, we haven't. And we would love to, but we haven't done it. Part of the nice thing about this is it's easy to get muscle tissue. And so I don't know. Yeah, there are probably other tissues out there that we could compare. So great question. The answer is no, we haven't done that, but it'd be really interesting to do.
Okay, people are very interested and there are a lot of questions, which is great. We're running a little bit over time, but I think we can take maybe a couple more minutes if you're okay with it.
Oh yeah, I'm fine. I'm
okay.
heading in. Yeah, it's no problem for me.
Okay. One question about interaction between colchicine and statin and how that might increase the risk of myopathy, especially as colchicine is being used more in cardiology.
Yeah, so colchicine is a potential myotoxin, and statins are a potential myotoxin. There's probably an additive effect by using them both together, but I don't know how well that is defined. Usually patients on colchicine do okay. Usually something else has to happen in order for that to be a problem. And a common thing that we see is patients who developed kidney dysfunction, they get increased levels of colchicine in their serum, and then they get a myopathy. Yeah, I should go back and look. There might be newer information about colchicine statin interaction that I don't know about, but definitely they're both myotoxins.
Yes.
Potential myotoxins.
There's a question about the mechanism of IVIG, and I think the answer is we don't know, but I'll let you answer.
Yeah. If anybody else knows how it works, let me know. IVIG has lots of effects, and one of the effects is that it probably decreases the availability of myositis-specific autoantibodies. That's my personal pet theory, right? Like I try to put everything back into the myositis autoantibodies. So, that might be one mechanism, but really, I don't know. I remember years ago, I thought I was just kind of an idiot, because I didn't understand IVIG. So I went and read a couple reviews on the mechanism of IVIG, and I came away thinking, oh, you know what? Nobody really understands how this stuff works exactly.
Okay, I think we'll do two more questions. One is the JAK inhibitors in patients with dermatomyositis who are already at high risk of cancer. Are you concerned about the adverse effect from the JAK inhibitors giving?
I worry about it. I do worry about it. Again, it concerns me, and especially in people where I'm thinking they're going to need long-term treatment. I do worry about it, and it's one of the reasons why they're, I think, at this point, not first line for most of us. You know, for most clinical situations, they're not first line. And again, I'm hoping that we see, more, you know, the emergence of similar drugs that are as efficacious but don't have the same side effect profile. But that remains to be seen.
Okay. And let's end with one last question, thinking about the future. This is a question from Dr. Weisham. Do you have any hope for treatments or something that you're excited about for IBM?
Yeah. So I do. So there is currently, so in IBM muscle biopsies, there are these CD8 positive T cells, which I talked about. Most of them, those cells also express other markers of highly differentiated, highly cytotoxic T cells. And those have been identified as, in monoclonal antibodies, therapeutic monoclonal antibodies have been developed to target them. And there is an ongoing trial of this therapy by a company called Abcuro, and they're moving into doing a phase 3 trial that should dramatically decrease or wipe out that population of T cells, the same population that seems to be invading the muscle. And so if that is the true mechanism of the disease, I think that therapy is super likely to be efficacious. On the other hand, if there's something else driving the disease and the inflammatory response is just a response to some other thing that's going on in the muscle, it may not be effective. So I think we're going to find out in the next year or two, but I would say this is the most promising targeted therapy that we've seen in a long time for IBM. I am hopeful that it will be effective, but we don't know for sure. But I think there is more hope than we've had quite in a while that there's something coming through the pipeline that may work. If that doesn't work, we're really in trouble in terms of finding targets for sporadic IBM.
Thank you. I think, yeah, hopefully we hear some good news about that.
Yeah.
I think we answered almost all the questions, or maybe all of them. Thank you so much, Dr. Mammen.
Oh, sure. My pleasure.